Okay, hello and welcome to the Internal Medicine series for clinical clerkships. Today we'll be discussing GI disorders, specifically the link between Crohn's disease and renal stones. So this is actually a very hot topic for Step 2 style board questions, and it will oftentimes deal with a case of a patient who has Crohn's disease, and then it will ask you, why is this patient getting renal stones? And many times the student will be kind of confused, not sure if it's because of the oxalate or the calcium. So we will be discussing in-depth pathophysiology regarding why patients with Crohn's disease are actually at an increased risk of renal stones. So to understand that, we need to first talk about Crohn's disease, right? So Crohn's disease is characterized by the hallmark of a transmural inflammation, right? A transmural inflammation of non-caseating granulomas, right? So if we take this back to the basics, we see that this right here is the intestine, is a layer of the intestine, right? Cross section. Right here we have the mucosa, right? The next layer we have is the muscularis mucosa, and the layer after is the submucosa, and finally the most bottom layer is muscularis propria. So in a disease like ulcerative colitis, right, you would expect that the mucosal layer is the one that is most affected. However, once again, the hallmark of Crohn's disease is that all of the layers will be affected by a transmural non-caseating granulomatous inflammation. And we can see that in here. So notice all of these little blue cells. So these are really lymphocytes and some neutrophils, right? We can see that all of this extends down to the bottom of the muscularis propria, all the way from the mucosa. So we can see that this is almost like a fissure-like inflammatory process taking place, right? And many times it's going to lead to fistula formations, and it's not too hard to imagine that with all of this transmural inflammation and fistula formation, you will have some element of malabsorption. And finally, the ileum is the most common site. So remember back in the kidney lectures, we talked about how, the most distal site is always a very important thing to focus on. So the ileum is the most common site of Crohn's disease. And remember, what's important about the ileum is that it's really along the gut, along the GI tract, right? The ileum is really the most distal place where there is reabsorption or massive reabsorption of fats and proteins. So we need to keep that in mind, right? So because there will be transmural inflammation of the ileum in Crohn's disease, you can imagine that because it's the most distal area where proteins and fats are getting reabsorbed, that the patients will often suffer from protein and also fat malabsorption. So now let's talk about how this relates to calcium oxalate stones. So right here we just see there's a calcium, and there's also oxalate right here, and here's some fat molecule, right? So this all ties back to the hallmark of transmural inflammation in Crohn's disease leading to fat malabsorption, right? So as you can imagine, if fat is being malabsorbed, that means it basically has to stay in the ileum rather than being reabsorbed back into the blood, right? And if there's excess fat kind of just lying around, right, in the ileum right here, just imagine I'm drawing a bunch of fat right here, okay, it will eventually undergo a process of saponification in which the fat binds with calcium, okay? So this is a very unique process to calcium and the negatively charged fats. So now you can imagine that the calcium will then not be available to bind oxalate within the GI tract, right? So because of this, you can almost imagine that the calcium is being lost. So let's talk about physiologically what happens between calcium and oxalate. So within the GI tract, within the intestines and the ileum, right, there's some calcium and there's also some oxalate. Now under physiologic conditions, these will bind each other and then get excreted in the stool, and that will not be a problem. However, here, now you can imagine that because there's fat malabsorption, all of this fat is staying behind in the gut, and it's instead binding the calcium, okay? And when it binds the calcium, it will leave the oxalate behind. And then now you can imagine that there's so much oxalate, right? And this oxalate is being massively reabsorbed back into the bloodstream by itself because it's unable to bind calcium and be excreted. So now you have hyperoxalated urea. So this is the pathophysiological process between why Crohn's disease leads to calcium oxalate stones.